to see so many people joining us today. So I presume I can share my screen again. Is that correct?
Yes, please. Yes.
Okay. Right. Is that clear? Can everybody see it? Am I doing it correctly? Can I start?
Perfectly fine. We can see your presentation. We can hear you fine.
Okay, so the topic that I was asked to speak about today is the side effects of radiotherapy, which, as we all know, are really significant in the head and neck area. Treating patients with head and neck cancers is sort of my bread and butter. That's kind of all I do. I also do skin cancer radiotherapy, which is most commonly involving the head and neck area as well. And so we, over the years, working with these patients, realize what the price is that they pay for the treatment that they undergo. And there are things that we can do if we understand what they're going to go through, try and make the symptoms less. And also, if they do develop side effects, we need to have some understanding of how to manage them. So I just wanted to go over a little bit about radiotherapy itself, just so that one has a basic understanding, because as far as I know, I'm talking to surgeons, and radiation is not something that you're that familiar with. So we use these machines called the linear accelerator to create X-rays. We can also use them to manufacture or create electrons, and we use both of them in head and neck cancer treatment. You can also treat head and neck tumors with protons and neutrons. We don't do that in our department, but we have in the past used them, and they are generated in cyclotrons, which are sizable machines, the size of a football field. And so there are not that many of them around in the world. And then in these same cyclotrons, they're very different ways that we treat patients. So of these atoms, they're absorbed into cells, and they then result in the production of fast electrons within these cells. And these electrons are the particles that do the damage, and they damage them either directly, which you can see here, an electron is damaging the DNA, or an indirect action where the electron actually forms an oxygen-free radical, and the oxygen-free radical then damages the DNA. And that is why it is important that oxygen is around when we radiate patients. And in head and neck cancer, that is significant when you look at some of the tumors that we see with massive neck nodes, where the center of the node is deficient in oxygen, and therefore much less to respond to the radiation. There is cell death, which is what we want, obviously, for our cancer cells, but not necessarily what we want for our normal tissue. So about 50 to 60% of all cancer patients will need radiation, and this is very in more disease. Many head patients present with advanced disease. So our radiation can be either curative or palliative. If we are trying to cure someone, we want to eradicate the cancer, and at the same time, we want to balance that against the morbidity that is created by the treatment. We almost always use combination therapy, chemotherapy, in other words, added to the radiotherapy. It's a long treatment, and I'll explain why in a minute. It goes on for weeks to about 2 months. It's usually about 2 months of treatment, and that excludes all the time that it takes to recover afterwards. And we are aiming for survival. So there's a price to pay, but we were trying to cure the patient. And so although we need to make sure there's not that much morbidity, we understand that patients are prepared to put up with a lot of discomfort if they can recover and survive. If we are palliating someone with head and neck cancer, we realize that cure is unlikely. And in our setup, and I'm sure in yours as well, this can form quite a large percentage of the patients that you see with head and neck cancer. We see a lot of patients presenting with advanced disease for many reasons. So here we're trying to relieve the symptoms and improve their quality of life. We often, almost always, only use one modality. In our situation, usually radiotherapy alone. Chemotherapy plays a much smaller role in treating head and neck cancer. And realize that there's survival, but we're trying to give the patients death with dignity and with as little pain and discomfort as possible. So it's very important to decide which patient belongs in which group. If we try to cure someone who's actually incurable, obviously incurable, you really are treating yourself. You're giving the patient a very unpleasant experience over a prolonged period of time, which might make up a significant part of what the time they have left, with many side effects and very little chance of cure, if not zero. So just to go into a little bit of detail, when we use radiotherapy for cure, we can either use it instead of surgery, in which case we usually add chemotherapy, and we call it definitive radiotherapy or curative radiotherapy, sometimes called radical radiotherapy. If the patient has had surgery and they've got an indication to have radiotherapy, positive tumor margins, etc., we call that adjuvant radiotherapy. And if we are using it before surgery to improve resectability of tumors, or to which doesn't really happen in head and neck cancer, but in other parts of the body, then we call that neoadjuvant radiotherapy. These are just terms, just for interest. If we're treating patients with palliative intent, we are only aiming to reduce the size of the tumor, relieve pain, stop bleeding, decrease edema. So if it's a metastasis in the spinal cord, or even neck nodes have a lot of edema, and sometimes they're pressing on vital structures in the neck and the throat and so on. Just decreasing the size of the tumor and the swelling can bring relief. So there's a very different slant between the radiotherapy for palliation and the radiotherapy for cure. So what causes radiation damage, and how can we minimize it or preferentially prevent it? It's very difficult in the head and neck area to prevent all side effects, but we really have to make sure that we minimize them. And the side effects that do occur, how do we manage those? So first of all, some interesting aspects to side effects of radiotherapy. And these also have, they're obviously important when it comes to treating with radiotherapy, but they're also relevant to exposure to radiotherapy in other settings. For example, in industrial accidents or radiation accidents. They can either be deterministic or they can be stochastic. So deterministic side effects, there is a dose below which there will be no side effect. So this is what we are aiming for when we are using radiotherapy for treatment. We know which dose we can't go above. I'll go into detail about that just now. If you exceed that dose, the higher you make the dose, the worse the patient's side effect will be. And then we also know that different tissues have different threshold doses. So there will be a difference in tolerance between the lens of the eye and the skin, for example. A very big difference, in fact. And then the other thing that we've realized over time is that different people have different threshold doses for different tissues. So there is a genetic predisposition to the side effects that people develop after having radiotherapy. The original studies were done on patients with breast cancer, and they know super radiotherapy than other people did. And now that people are looking into the similar things in patients with receiving radiotherapy for head and neck cancer. So we have a genetic predisposition to these side effects. So the deterministic side effects are all the early side effects that you get with radiotherapy and most of the late side effects. And then the stochastic side effects are completely different. There's no dose beyond or above or below, whatever, that you can say, well, you will or you won't get the side effect. We don't always know what the dose is for these, but we do know that the higher the dose goes, the more likely it is that these side effects will occur. And this refers to the side effect of developing a second cancer in a patient who's already had one cancer and received radiotherapy, and also possibly developing mutations that can then be passed on to your offspring. So this is a very different type of side effect, and we're not really going to talk about those today, but just to know that it's there. The one that comes to mind would be somebody treated for retinoblastoma in childhood who got radiation to the orbit and then goes on to develop osteosarcoma or skin cancer or a sarcoma of soft tissues in the area of the face that received radiotherapy 20 years before. So that's just an example of that. But we are going to focus more on the deterministic side effects. So there's a bit of history here. Radiotherapy has been around since the late 1800s. It's been used for treatment since then, although in a very crude way initially, and people initially played around with it without having any idea about what was going to happen as a consequence. And here are some of the scientists that developed side effects way back in the late 1800s and early 1900s. This man documented the damage to his hands, and then he eventually died of radiation-induced cancer. Thomas Edison, who we all know invented the light bulb, he realized that it was damaging his eyesight, and his assistant eventually also died of skin cancer and also lost fingers and an arm. So these people were pioneers, but they certainly paid the price, and it was the start of people realizing that radiation was not harmless. So back to why and we can use radiotherapy to kill cancer cells and how we try to balance that against the damage to the normal tissue. So normal cells are capable of repairing the damage that's done to them by the radiotherapy. So it's not as though when you radiate someone, only the cancer cells suffer. Obviously, all the cells are damaged, but we have got DNA repair enzymes, and they will repair the damage done by the radiation within 6 to 8 hours of the radiation dose, provided that you don't exceed the tolerance dose of that organ or tissue. Obviously, if you go over that dose, repairable, it takes as little as 6 to 8 hours to recover from that. And that has allowed to treat people up to 3 times within 24 hours. There are studies that have done on changing the way radiation is given and trying to give it over a shorter period of time in head and neck cancer specifically. And they only allowed an 8-hour gap between each treatment for these patients. And sometimes in other studies, treated them twice a day. But it just proves that your normal tissue can recover. Cancer cells, because they are abnormal, however, are not able to repair the radiation-induced DNA damage. And so they go on to die, hopefully most of them. Obviously, that's not an all or nothing thing because we know that not everybody is cured with radiation treatment, but the majority of the cells will not be able to recover from the DNA damage. It's quite an anomaly because obviously cancer cells are growing out of control, and so they have developed multiple mutations that allow them to grow uncontrollably, but they are weakened in some aspects, and so therefore are able to be preferentially killed by the radiotherapy and not the normal tissue. So every tissue, I've mentioned already, has a tolerance dose that if exceeded will result in permanent organ damage. And that happens because you're damaging the stem cells that are in that organ. And once you damage the stem cells, those stem cells cannot regenerate, and that is going to cause permanent damage. It might be now, it might be later, but it is not going to be recoverable. And over many years, people have worked out what these tolerance doses are. So radiation, I always think of it as being a triad, and it is a play between the dose that you're going to give, the dose per day, as well as the overall dose over the 6 weeks or 7 weeks that you're going to give it, versus the volume of tissue that you're going to treat. So if you're treating to a high dose and you're treating a small volume, you can get away with a lot more radiation than if you're giving a high dose to a large volume. And then the time that you give it over is also important. So if you're wanting to give a very high dose of radiotherapy, you need to give it over a long period of time. And you do that by giving a small fraction of treatment every day for about 6.5 to 7 weeks in the case of radiation to the head and neck. So if you want to give treatment over a short time, you won't be able to give a very high dose, and you certainly won't be able to give it to a very large volume. So we play around with these three things, or we don't play around with them. They've been worked out scientifically, and we manipulate them slightly to give the treatment that we want to give. So we also have tissues in our body. I mentioned that we have a genetic predisposition to different to damage from radiation, but also there are tissues in our body that have a rapid turnover. If one thinks of the mucous membranes in the mouth, all the way down through the gastrointestinal tract, the bone marrow, and so on. So those are the early responding tissues. The late responding tissues are tissues that have a very slow turnover. Classically, nerve tissue is the one that one thinks of. There's also the prostate and other tissues. There's long lists of them. But just to remember that each type of tissue will respond differently to radiotherapy. One thing to remember is that the DNA damage that's caused by radiotherapy only induces cell death when that cell tries to replicate. It doesn't kill it like a gun kills with a bullet. It stores the damage, and it only manifests that damage once it tries to reproduce, to multiply. So you can imagine that late responding tissues that take years to turn over might only manifest their radiotherapy damage years down the line, whereas the early responding tissues will be damaged almost immediately because they're literally turning over every 24 to 48 hours. Then the structure of the individual tissues is also very important. For example, if you damage the spinal cord, because of the way it is struck, the sort of inherent structure of the organ, even if you only damage part of it, you're going to end up having damage that is not recoverable. Whereas, for example, with other organs like the parotid gland, you can damage some of it, but part of it will be able to continue functioning. You won't be able to get your spinal cord to function even if you only damage a small part of it. It's not able to do that, simply just due to the structure of that, the way the tissue is constructed. We also, the early responding tissues and the late responding tissues, we talk about the alpha beta ratio. So that's not anything you need to worry about. It's all about radiobiology. And we know that there are different alpha beta ratios for late responding and early responding tissues, and we can do certain mathematical calculations to work out what doses each organ can tolerate. Then in the 1990s, using all the research that had been done from the late 1800s up until then, these tables were developed that allowed us to look up and see which organ could tolerate which dose. And then these have been replaced essentially by the Quantec tables, which are just they're more detailed, and they have been developed to a sort of cater for intensity modulated radiotherapy, which is really the sort of way modern radiotherapy has developed. And it just allows you to work out a percentage of each organ that can tolerate a certain dose. So the whole organ can tolerate a much lower dose, obviously, than a small part of that organ, obviously, depending on which structure you're talking about. And then all of these vital organs, we just give them this term called organs at risk. Obviously, all normal tissue is an organ at risk, and you want to preserve it. But although you might not like to have radiotherapy damage to your skin because it's cosmetically unattractive and it might be uncomfortable, it's obviously a completely different situation if you end up with damage to your spinal cord and become a paraplegic. So we prioritize certain organs at risk, and no matter what treatment is needed, we will almost never overdose any of these organs at risk because the consequences are life-threatening. So just to differentiate again, a little bit more between the sort of acute side effects and the late side effects. Acute side effects happen with all radiotherapy. You can't avoid it, and you certainly can't avoid it in head and neck cancer. They define it as within 3 months of treatment, but in actual fact, they commence during treatment. They happen sort of almost immediately. They are due to the direct effects of the radiation on the cells of the rapidly dividing tissues, which I've mentioned already. That's because they are turning over very quickly, and therefore as they divide, they manifest the DNA damage and they die. The examples would be the skin reactions that we see in head and neck cancer, radiotherapy, and the mucositis, fatigue, loss of taste, the thick saliva. They generally recover provided the radiotherapy has been given within tolerance of those organs. Some of them obviously go on to become late effects, but thinking more of sort of dry mouth. But all of these go away and if you haven't exceeded the dose. And here are some examples. I've really picked some extreme examples to keep things interesting. You can see here, this is a serial photograph of someone who is going through a course of radiotherapy to the neck. You can see starting off with just some redness and dry, scaly skin, then starting to what we call desquamate and become slightly moist. And now this is true moist desquamation, where all the sort of superficial epithelium is denuded and you just have the underlying tissue exposed. It's sore, it's red, and it often oozing a lot. You can see here, this is more the sort of little bit of wet desquamation there perhaps, but mainly the dry form. This is the crusting when that dries and then cracks and opens up again. And this is obviously a very advanced situation and should not really be allowed to happen. I'll come back to the skin reaction in a minute. I just wanted to point out the alopecia that you can also get with radiotherapy. This usually recovers, but it's not guaranteed, and often people lose a part of their beard, or they can lose their hair at the back or on the side, depending on where you're treating. This is because the follicles of your hair follicles are also rapidly dividing cells, and therefore they sort of are sensitive to the radiotherapy. Just to point out that these images are really seen still in many. We see less and less of it because we're doing almost exclusively IMRT, where here it is here. But if you are treating with 2-dimensional radiotherapy or 3-dimensional radiotherapy, these sort of skin reactions are far more common. And they are very uncomfortable for the patient. And although they heal up, when they get to this degree of severity, they are not going to heal up without scarring. And so they should be avoided if possible. The reason they develop just by for interest sake is that the surface of the neck and the head is very irregular. So you have areas of radiation that are higher and areas that are lower. So we call them hot and cold areas. And so there are areas that are getting slightly overdosed and slightly underdosed, and the dose of the radiotherapy is right on the skin. And the dose on the skin is high in order to achieve a high dose within the sort of central part of the patient to treat the tumor. So the skin sort of pays the price. But as I say, with modern radiotherapy, we are not really seeing much of this anymore. So here is some examples of what goes on inside the mouth. You can also see how uncomfortable that looks. You can see that typical thick saliva. You can see the sores, the dry mouth, and you can see these sort of ulcers that eventually coalesce and form sort of a complete membrane on the inside of the mouth. This mucositis begins almost like clockwork at 20 gray. We give 2 gray per day, 5 days a week. So you can see that by the end of the 2nd week, out of a 7-week treatment, patients have got sore mouths and sore throats, and it just gets worse from there. Then it tends to plateau. And we always warn them that for the couple of weeks after they complete their radiotherapy, certainly for the 1st week, it usually gets worse before it starts to get better. So it's a long journey. Loss of taste is also significant for the patients, and the thick saliva, it might not sound like an awful thing to have, but for the patients, it is a real problem. So you're dealing with people who are struggling to eat already, and then you add the loss of taste and the thick saliva, and it becomes very, very difficult for them to maintain their nutrition. So late side effects develop 6 months after treatment by definition. They affect the slowly dividing tissues, and they are not due to direct damage to the actual cells in that organ, the actual tissue of that organ, the liver cell or the squamous cell or the whatever cell. They're actually due to damage to, they're caused by damage to the blood supply to that organ. So the radiation has then damaged the endothelium of the blood vessels, making that tissue relatively hypoxic and causing fibrosis. And it is that progressive damage to the blood supply of that organ that results in these late side effects. Examples of these would be fistulas, ulceration, fibrosis, telangiectasia, and then of course in children, growth arrest, which we do irradiate children, but less commonly for head and neck tumors, but this is something that is a big problem if you do have to treat children. The unfortunate thing about these late side effects is that they get worse with time. They do not get better, so once they start, they don't go away. And these are again some very extreme examples. You can see somebody here who's had treatment for probably a larynx, post-laryngectomy. He's got a stoma. You can see the very thin, very fibrotic neck. Here's another patient with the same look. I'm not sure if it's the same patient or a different one, but just you can see the very tight, hard neck. We describe this as woody hard. And once again, with IMRT, we are not seeing that anymore, except in patients who really have a predisposition to these changes. And here's a lady who's got the same changes as this man, but interestingly here, I found this image. This is what she looks like after fat injections. It does not relieve the symptoms of the tight neck, but it is a cosmetic intervention that can be done by plastic surgeons. They harvest fat cells from the abdominal wall and inject it into the tissues of the face and neck to fill in these hollows and therefore give a fuller appearance. And then this is just an example of severe telangiectasia post radiotherapy to the neck, where obviously the dose to the skin was very high, because the skin has a very high tolerance for radiotherapy, but this is obviously this tissue has received a very high dose. Again, cosmetically very unappealing for that patient and unattractive. These are side effects that also happen as late side effects. You get typical changes in the mouth and the teeth after the mandible and the mouth have been exposed to radiotherapy. Here you can see this cherry red bone dry tongue, which we get if the salivary glands have been damaged by the radiotherapy, and it is incredibly difficult to not damage the salivary glands when you treat the head and neck area. You're almost always going to damage the submandibular and sublingual glands. We do try very hard to save at least one of the parotid glands, keep them below their keep one of them below tolerance. But even then, for some patients, that's not enough, and they end up with a dry mouth anyway. And they have to walk around forever with a bottle of water trying to wash their food down, and sometimes they can't even speak unless they wet their mouth with water. So it's a very unpleasant side effect. And a lot of research has gone into trying to prevent this. Again, with IMRT, you can try to spare more of the parotid gland, sometimes sparing the outer lobes and only sort of catching the inside can maintain some hydration. And as I said, if you can save one whole gland, that does make a big difference. The discomfort. It accelerates the damage to the teeth that you see here. By changing the saliva in your mouth, you create an imbalance between the bacteria in your mouth and the bacteria that cause caries overgrow. So when you've got a healthy mouth with lots of saliva, you've got good bacteria that tend to keep the bad bacteria at a minimum. As soon as you unbalance the pH and the composition of the saliva in your mouth, the bad bacteria take hold, and you get carie formation that's very rapid. The other thing just to mention is that the minor salivary glands in your mouth are just as important as the major salivary glands in your mouth, because all your salivary glands create different types of saliva, and you actually need all of them. But again, it's very difficult to spare the minor salivary glands if you're treating the oral cavity. Trismus is a very unfortunate side effect. Sometimes it's caused by the tumor, and it's already present when the patient presents, but sometimes the radiation really damages the muscles, especially when you're treating the tumors in the oropharynx, if they've gone backwards towards the pterygoid muscles. And you can see with this patient with teeth that are still there, it's almost impossible to get food into her mouth. You have to try and drink through a straw, through a gap, and so on. And this is a big problem, and it's usually progressive. And then the dreaded osteoradionecrosis that we see, This can be caused by many things. We know that some patients are more susceptible to it. The higher the dose, the more likely it is to occur. You can see this exposed mandible here. You can see the exposed mandible within the mouth, and it corresponds with the lucency on the X-ray, on the Panorex X-ray here. We know that people who are poorly nourished, who continue smoking, people who have dental problems that are not attended to before their radiotherapy and then go on and have extractions after their radiotherapy are far more likely to develop this side effect. And I'll talk a little bit more about it later. I also just want to mention that this osteoradionecrosis and osteopenia does not only affect the mandible. I have had patients who've had osteopenia and actually progressing onto osteoradionecrosis of the cervical spine. And presenting with cervical spine symptoms and nerve compression and so on. So it is not only about the mandible. I've also seen it in the hard palate. So any bone that has received a high enough dose of radiation can develop osteoradionecrosis, but the mandible is the most likely because it has all sorts of other problems like having rotten teeth in it and so on. And it does get a very high dose in some, especially cancers with the floor of mouth. So some more late side effects of head and neck radiotherapy: swallowing abnormalities related to the fibrosis of these tissues in the neck, malnutrition, which can be related to the swallowing abnormalities, or it can actually just be the person just not doing well in general, finding it very difficult to get enthusiastic about food with a dry mouth. And with no saliva and no teeth, and often with pain and so on. With the swallowing abnormalities, we also sometimes see aspiration pneumonia. Neuropathic pain, I think, has been very underestimated in head and neck cancers. I think that especially patients who have had surgery and then go on to have radiotherapy have sometimes quite a high incidence of neuropathic pain, and it just isn't diagnosed and treated as often as it should be. Myelitis, I've written here, it's very uncommon to see that. You need to really overdose the spinal cord. But it has been seen in the past when people weren't as aware of the tolerance dose to the spinal cord, and actually it's a transverse myelitis and results in paraplegia. And then, of course, hypothyroidism when you're radiating the neck is something that can develop. That's fortunately treatable. With swallowing difficulty, some patients might need a nasogastric tube even starting during their treatment. We need to keep up their nutrition, but obviously that's not a permanent option in most patients, so we might end up having to put in a feeding tube, a PEG or some other form of feeding tube that needs to be kept in situ for the duration of the treatment. To resist doing this, it's not that available to us, so we tend to put in nasogastric tubes more commonly, but for a short time. It is well recognized that patients who develop who need PEG tubes or have them done prophylactically before radiotherapy, there's a high incidence of them becoming what we call PEG dependent. So they then end up relying on this tube for the rest of their lives. We tend to push patients and try and force them to swallow at all possible. And even if they have a nasogastric tube in, that doesn't mean that they mustn't eat. So we try to get them to carry on. It's very important. I was taught that when I was training. The professor I trained under used to tell the patients to swallow brown bread because he said it got rid of all that gunk at the back of their throats. And although it was painful, they could
yeah, ENTs are going first, the airways.
So the late side effects, as I've demonstrated now in those slides, they have to be avoided at all costs because the morbidity is really severe and death is not uncommon. It's not uncommon for patients to die of side effects of treatment after many years if the doses that they were received were high enough. You can imagine aspiration pneumonia, malnutrition, and so on can definitely result in death. So how do we prevent these late onset side effects? We have got the knowledge that has been gained over these 100 years has allowed us to work out what we can get away with, and that's the best way I can describe it. This little picture here with the scales balancing complications versus tumor effects is also reflected in this graph here, and also in this mathematical sort of formula, where that we are balancing normal tissue complications versus the dose that is necessary to kill the cancer. And this varies from tumor to tumor, but in squamous cell carcinomas of the head and neck, it's pretty standard. It's a range that's sort of in the sort of 60 to 70 gray, depending on the situation. And we know that that is exceeding certain organs at risk in the head and neck area. So we have to use other means to try to shield these normal tissues. One of them is to fractionate the dose, and I've mentioned that before. You give a little bit of treatment every day for a long time. We also shield the adjacent normal tissues, and I'll show you how we do that. We also make sure that patients are in exactly the same position every day so that we don't miss the tumor and treat the organ at risk by mistake. We use computerized planning, which is very helpful to make sure that everything is as accurate as possible. And then that's the sort of next stage would be intensity modulated radiotherapy, where we are trying to push the dose, more sophisticated computerized planning. So this is just a sort of diagrammatic way of showing how we optimize the therapeutic ratio with the points that I mentioned on the previous slide. So first we immobilize the patient. This is a thermoplastic cast. You can see it's been molded around the patient. There are lots of things drawn on it as reference points for the radiographers. The patient puts that on and is scanned. We do a planning CT scan in that cast, and that cast will be used throughout the treatment. So it's very important that it fits properly and that it stays fitting properly. We then do computerized planning, which optimizes the dose to the tumor and minimizes the dose to the normal tissues, hopefully. And the plan will look something like this. This is what we look at when the radiographers call us to have a look at what they've done. And we'll say, oh, I'm not happy about the dose to the spine. I'd like it to be less, or can't you spare the parotid a bit more? And then they will play around, and then eventually we will reach a plan that we are all happy with. The patient is then put onto the bed, the treatment bed. This is the linear accelerator. This image here is just representing the shielding of normal tissues. We use in the modern radiotherapy machines a multi-leaf collimator. These leaves can move in and out. They're controlled by the computer, and they shield the normal tissues. And in this open area, you can see here, the radiation will come through undisturbed and straight onto the tumor, and hopefully all the areas around it will receive the dose that is within tolerance. And this is the patient immobilized in this cast every day, and they're receiving treatment from the linear accelerator through this multi-leaf collimator, which is shaped to spare the normal tissue. Just to mention, we have a new machine that is doesn't look like this at all. It actually looks like a CT scanner with a barrel-shaped portal that the patient lies in, and that allows us to do onboard imaging using a CT scan, a cone beam CT, every single day to ensure that the patient is in the correct position. So this is wonderful for head and neck treatment, because it means that every day the patient's position is checked against the planning CT scan that was done on day one. And then the computer helps to adjust the patient if the computer feels that the positioning is not exactly accurate. And then this is what it looks like if you projected this onto an X-ray. You can see where these white lines are. This is where we are shielding normal tissue, and this open area will be where the patient receives the dose to the neck nodes and the oral cavity, or the bottom of the oral cavity. So that's just an example of how we try to spare as much normal tissue as possible. So what is very important when it comes to minimizing side effects for patients who are receiving radiotherapy to the head and neck is that you start preparing before you treat them. They have to be sent to a dentist. All extractions must be done before, at least 2 weeks before the radiotherapy starts. If they don't need extractions, rotten teeth the holes must be filled. You treat the gum disease, you give fluoride treatments. You tell them to stop smoking, which is very important. You refer them to a dietitian so that they understand what's going to happen with their eating and what they can do to stop themselves from losing weight. And then you start telling them about how to look after their skin during treatment so that they're not taken by surprise on the day. And then also patients who have receiving treatment near their eyes, just a little note is that it helps if you can send them to an ophthalmologist to put stents in the lacrimal ducts, because certainly if you're treating skin cancers on the nose or anywhere near the eyes, there will be a significant dose sort of scattering towards the eyes, which may not cause more than a bit of conjunctivitis, but actually that's enough to result in stenosis of the lacrimal ducts in the long term. So during radiotherapy, then I can't emphasize enough how ongoing nutritional support is important, and it's because of the patient's many reasons. So one of them is, of course, we want them to still fit into their cast exactly as they did on day one. But other reason is that obviously if people become malnourished during their treatment, their immune system is suppressed, they are much less likely to do well, their mucositis could potentially be worse. It's just generally trying to maintain the best health that one can. And it is very, very difficult. These patients do not want to eat. They actually don't care if they eat or not most of the time. And it is really quite a battle. And without intensive supervision and nagging and hopefully getting support from family members to prepare special food and so on, it's a very difficult thing to get right. And so it's very important that the doctor understands how important it is. Analgesia is important. A lot of patients will tell you they don't swallow because it's too sore. That is not acceptable in this day and age. We've got very effective painkillers, and patients should not be unable to swallow because they're in pain. Be that as it may, obviously analgesics have their own side effects, so one has to be aware of that. We also use topical analgesics in our antiseptic mouthwashes, which have a bit of local anesthetic in them, and then you've got Mucaine, which is an antacid, which you can rinse your mouth with and gargle, and which and then swallow, which also helps. And we also sometimes need to treat for secondary fungal infections, but that's not as common, I think, as people think. Just to mention, when it comes to the mucositis, I've put it here. There are drugs that have been tried over the years. There's one called amifostine, and we're actually busy with a study at the moment on a new drug, which is being given concurrent with chemoradiation to try and lessen the mucositis that patients experience, because I cannot emphasize enough how terrible this is for the patients. Amifostine really has got so many side effects, including dropping blood pressure, and it has to be given intravenously, and it makes the patients feel terrible, and it really just isn't used anymore. And we'll see what these new drugs that are being developed come up with. It's interesting because it's being developed, it's being tested on radiotherapy patients, but it's actually essentially in the future going to be also used in people who are having bone marrow transplants, and especially in children, and also having other immune therapies who develop severe mucositis, which isn't related to radiotherapy, but more to the chemotherapy. So that there are some drugs that are being tested, but so far there's nothing that works that we know of to lessen the mucositis other than symptomatic treatment. And then the skin reactions I've shown you some pictures, although they might not be as severe as that anymore. Patients will get a sore, tender skin, a bit like sunburn. If it itches, we tell them to put some corn flour on it. They can use Vaseline if it's very dry, but they must warm the Vaseline so that they just pat it on. There's no rubbing of the skin allowed. There's no washing of the skin allowed, because they can literally take off the top layer of their skin if they are too rough on that skin. If they do have some desquamation, then we tend to give them dressings. Sometimes we use topical steroids and so on. We often use a dressing sister to help us with these topical treatments for the neck skin. And then not to forget emotional and social support. This is a really, really difficult treatment for patients to go through, and they cannot do it without support. It's unrealistic, and they can end up very miserable and depressed. And worst of all, if they're not supported and the things aren't explained and they don't have the treatment that they need, they usually just stop coming for treatment, and that's the last thing you want. And then after the radiotherapy, it's an ongoing thing. This is one group of patients that I believe should be followed up for life, or certainly for at least a decade after their treatment, not only because they tend to develop new cancers, but because they forever struggle with their nutrition. I did a survey last year on all our oropharynx chemo radiotherapy patients, and almost universally I discovered that they did not go back to their starting weight, except in a few circumstances. And I looked at quite a lot of patients. So nutritional support is a big issue. Obviously, a lot of patients in our setting are going back to suboptimal financial situations, and so they need nutritional support supplied by their local clinic, and so we refer them for that. They must be told to stay away from cigarettes if they possibly can, although that's not that easy. You need to specifically ask about symptoms of swallowing difficulties, aspiration, and so on. And if there is anything that you're worried about, you can do a barium swallow and try and evaluate that. They should continue to go to the dentist if they have teeth for the rest of their lives every 6 months, for fluoride treatments and to treat gum disease and to try and keep their teeth in as healthy a condition as possible for as long as possible. You monitor thyroid function, which mustn't be forgotten about. Analgesia, they might need analgesia long term, if not always. One tries to wean them off the opiates and so on, but it's not always that easy. And then as for during the radiotherapy, you need to monitor their quality of life. It's not always that easy to reintegrate into your old life after head and neck radiotherapy. They might need to have job assessments and so on. They might need to have financial support. They might not be able to work again. It's quite common in patients who've had surgery to the neck with neck dissections and then radiotherapy to develop problems with their arm function and their shoulder function. And if they are manual laborers, it's not that easy to go back to work after this intensive treatment. One obviously wants to encourage them to, but it's not always possible. So just a word on osteoradionecrosis, which is a horrible thing. Prevention is better than cure, obviously. Nutrition before, during, and after treatment is very important. Whether you add vitamin supplements and all sorts of other things, I'm not sure, but just good nutrition is essential. The patients should not smoke. It's definitely known that it's obvious that patients who smoke will have a much higher risk. And the reason is that the smoking is just aggravating the ischemia that is already being created by the effect of the radiotherapy on the blood vessels. And then dental work has to be carried out with utmost care. So it's nice if you can send the patient to a dentist who's experienced with patients who've had radiation, but it's quite uncommon for one dentist to do that except in a hospital setting. We usually just give a little letter with instructions that the patients must be, if they're going to have extractions, they have to do it as delicately as possible with as little manipulation of the tissues, the gums and so on, and no rough pulling of teeth. It has to be done very, very carefully. Might need a general anesthetic in that case. And also they need to give them antibiotic cover. They can give them a dose before they start manipulating and pulling out the tooth, and then they need to continue for 5 days afterwards. That's the best one can do to try and prevent the development of osteoradionecrosis, because we know that patients who have teeth extracted after radiotherapy have a much higher risk of radionecrosis. It's also just interesting that if you do it within the first 6 weeks of the radiotherapy, it is much less risk, but it's once you start working on the teeth, once the sort of late effects start to set in, that you have the higher risk. So if you have osteoradionecrosis, the treatment is to refer them usually to maxillofacial surgeons who debride dead bone, dentists to attend to any dental problems. We sometimes need to give them antibiotics, sometimes for long courses of antibiotics. I'm not sure what the benefit is of antioxidants and vitamin supplements, but people sometimes give them. The hyperbaric oxygen is a very contentious issue. It's definitely necrosis, but I think that it was possibly the case of the baby being thrown out with the bathwater, as they say, because I think if you catch the osteoradionecrosis before it actually develops, if you feel that somebody, for example, needs to have dental work done, and if it was affordable and available, and you actually gave them the hyperbaric oxygen course, which is several treatments usually, before and after the dental work, you could probably prevent the osteoradial necrosis from developing. It got a bad name, or was labeled as ineffective and unhelpful because people try to use it to treat established osteoradial necrosis like the one you see in the picture here, and that's obviously not going to be fixed by anything other than surgery. And here the patients then end up having resection of a part of the mandible and then a free flap reconstruction to fill the defect, either with or without bone, if you can do that from the fibula. Otherwise, it's just soft tissue to reconstruct the defect. But once the radio osteonecrosis is established, it's not that easy to get rid of it, and sort of less invasive have lasting effects, and they end up needing quite dramatic surgery. So that kind of surgery is not freely available in all places. And so the prevention of osteoradial necrosis is essential, because if you do end up with a really bad situation, it might not be that easy to treat the patients. So treating cancers of the head and neck is something that has to be undertaken, I believe, by a multidisciplinary team. It's not just about the doctors, the radiation oncologists and the ENTs. It's also about the social worker, the psychologist, the dietitian, the speech therapist. Speech therapists are invaluable in helping with swallowing, evaluating and assisting with swallowing difficulties. And it's also our nursing staff that are a lot of radiotherapy is now for the head and neck is given together with chemotherapy, and I haven't even mentioned the side effects of the chemotherapy. I've stuck purely to the radiotherapy side effects, and often have side effects of the chemotherapy, for example, neuropathy in the hands and feet, and hearing problems, and potentially kidney damage, and so on. So it is, as I said, a very difficult treatment for patients to go through. Patients are often not in the greatest health when they start their treatment, and so nursing them and carrying them through this so that they complete their treatment on time and hopefully are cured is quite a challenge. There are many vital structures in close proximity in the head and neck, and the treatment is very difficult, and the side effects are unpleasant, even if they are mild. So if you look at someone and you say, oh, it's just a dry mouth, it might appear to be a mild side effect, but for that patient, it can actually be, it really impairs their quality of life. And we need to follow them up long-term for the many reasons that I have mentioned. So that is the end of my talk. I hope that you heard most of it at least. And if anyone would like to ask questions, and I'm here.
Great. Thank you very, very much, Dr. Wetter. That was an excellent, very detailed and exceptionally informative lecture. Thank you very, very much. I just remind the attendees that if you have some questions, you can type them on the chat function, or you can do the raise hand function, and I can give you, I can unmute you, and you can go ahead and ask your question yourself. Professor Fagan, anything from your side that you'd like to comment or add?
No, I'd just like to compliment Sir Julie on their presentation. I mean, I've got the privilege of working with her, and our patients have the privilege of being cared for by her. And I think, you know, often tell people that just like you get good surgeons and bad surgeons, you also get good oncologists and bad oncologists. You know, and I think it's just such a specialized field. You know, that one really wants to refer your patients with head and neck cancers to oncologists who have a special interest in this area. Thank you very much, Julie.
Pleasure. Thank you.
Dr. Wetter, we do have a few questions on the chat line. We can just maybe quickly go through them in the interest of time. But the first one is perhaps can you comment on
Yes.
the effect of concurrent chemotherapy on the side effects? I know you alluded to it very briefly, but just expound slightly on the effects if you add concurrent chemotherapy.
Yes, so that is a very, very good question. And it's a very interesting answer, because what we do when we add chemotherapy is we know that we increase the effect on the tumor by about 8 gray. But that does not translate into more side effects in terms of the radiation side effects in the head and neck area. So when I spoke about chemotherapy side effects, I was talking more about the actual chemotherapy side effects on the body itself. You know, the peripheral neuropathy, etc. It's interesting that what the chemotherapy does is it increases the effectiveness of the radiotherapy without increasing the long-term side effects. It will make the short-term side effects worse. You know, they probably have more mucositis, more everything during the treatment, and certainly you'll feel worse because you're getting chemotherapy as well, but you will not have worse long-term side effects. So that is why it was such an exciting development when people realized that they could give the same dose of radiotherapy but make it more effective by adding the chemotherapy. It is a radiosensitizer for the tumor, but if you use it carefully, you are not making the long-term side effects worse.
Great. I'll just quickly move on to the next question, Dr. Wetter. So maybe just a quick comment on hyperfractionation and accelerated fractionation.
Okay, so many studies have been done to look at different fractionation regimens. One of them we took part in, the DeHanker study, which was looking at giving 6 fractions a week instead of 5 fractions. And that was found to be comparable to giving chemo-RT, chemoradiotherapy. So then it's quite a nice option if you are able to do that, which we aren't because you obviously need staff to come in on a Saturday. You can then give patients 6 fractions a week and you can leave the chemotherapy and you'll have the same outcome. Then I mentioned the ability of normal cells to recover within 6 to 8 hours. And so there were some studies looking at giving patients as much as 3 treatments per day in a 24-hour period. That was the CHART study. That was shown to have good effect, but the acute side effects were very difficult for the patients to tolerate. So that has never really been put into practice. It's also completely impractical to expect radiographers to be on duty 24 hours a day in order to bring these patients from the ward to come and treat them. So these were very experimental and proved certain points, but are not practical to use always. And then there are some others where they've used a concurrent boost, which we sometimes use, where you maybe give a certain dose per day to a larger volume, and then within that, to just boosting the tumor, you will actually give a higher dose per day to the tumor to a smaller volume, and that is a form of accelerated treatment. And so all of these manipulations of the fractionation are very useful in head and neck cancers, and it just depends on what your resources are and what your abilities are in terms of complex computerized planning.
Great. Dr. Wetter, if you just check the chat function, there are a number of questions, and maybe you can, just press on it and see which ones you can quickly go through. In the meantime,
how do I find the chat function?
It's just in front of you. If you just see where the
hang on.
Yes, yeah. If you just press chat.
I've only got symbols here, and at the top it says. Oh, here we are. Sorry, it's under more.
No problem, no problem. In the meantime, I'll ask perhaps somebody from a different country just to comment. Dr. Kenneth Baidu, would you like to perhaps comment on what the experience is like in West Africa?
Good morning, everybody.
Hello,
Julie,
Kenneth.
thank you very much. I hope everybody is well. Yes. Down here, yes, we have a very nice radiotherapy setup, and we contend with similar things. And I was hoping something has changed since I was in UCT, but it's not changing much. But basically, it's across the world. So yeah. We have to deal with these patients, and like Julie said, the most unpleasant thing is the mucositis, and it's a daily thing we have to try to explain to the patients. But I think pre-op, if the patient has some counseling, it's easier for them to deal with the situation. But we accept before they go into therapy, they have a lot of anxieties, and I don't think they even think about the little things we try to tell them. So we have to re-emphasize them on and on to make them feel it. Thank you very much.
Okay, thank you, Kenneth. Shall I try to answer some of these questions?
Please go ahead.
Okay, so I'm going to start at the top. These are all the sort of more the registrations. Let me just see. I saw one that asked about how to treat xerostomia.
Yes.
So, there's no treatment other than symptomatic treatment, and for patients that can afford it, there are some artificial saliva solutions that you can buy, and there's also some mouthwashes that are supposedly able to stimulate some saliva production. Some people find, little, I don't know, one patient told me about some kind of vegetable that he ate that made a difference. I can't remember what it was, but it's not easy to treat, because whatever you do, if you think about it, you swallow your saliva. So even if you sprayed your mouth with an artificial saliva, at best it'll last 15 or 20 minutes. It's not going to last forever. So it really is about trying to prevent it. And then symptomatically, the patient will work out what works best for them. But most patients can only really use water, because these other mouthwashes and things are not cheap, and it's not something that we certainly don't supply them at the hospital. When I first started working here, many years ago, our pharmacy actually made up artificial saliva, but they've stopped doing that. So there is no treatment that I can mention other than these commercially available products.
Okay, great. Thank you very, very much, Dr. Wetter. There are a number of questions here, but in the interest of time, I think I'm just going to just maybe stick to one or two last questions. What experience do you have with pituitary side effects of radiation, and what do you look out for?
So pituitary side effects are almost exclusively going to be related to the patients who've had radiotherapy for nasopharynx carcinoma, because that's the time that you go into that area. It's also a problem with treating the orbit. So I treat a few, often, not often, but every now and again, a patient who's got either the tumor that's grown into the orbit or that originated in the orbit, and you now need to extend your radiotherapy posteriorly because there's been a breach into the cranial cavity or whatever. We try to keep the tolerance of the pituitary and the chiasm as low as possible. And so it's very difficult to overdose the pituitary if you are keeping within the tolerance of the chiasm, which is sitting right above it. So it would be unusual to overdose the pituitary, because you're being so careful about the optic chiasm. And so even in patients who've been treated as children for retinoblastoma, where both eyes have been removed and they got external beam radiotherapy right through from left to right, and obviously included the pituitary, it seems to be a pretty resistant organ because they don't tend to present with that many side effects. So it's not been a significant problem in my practice, because I think we tend to make sure we don't overdose it.
Great. Dr. Wetter, last question now, because I see there are a number of more questions flowing in, but maybe last question is, maybe just expound on some radiosensitizers being used in clinical practice.
Okay, so the ones that we use are the chemotherapy drugs. We use cisplatin, and we use carboplatin, which is another platinum agent. Some people would use carboplatin in conjunction with another chemotherapy drug called 5-fluorouracil, but that's quite toxic. One has to remember, whatever radiosensitizer you add, it's going to increase the toxicity for the patient. And so the other one would be to use cetuximab, which is a biological agent that is more easily tolerated certainly by people who are more elderly and aren't fit for a platinum agent. The trouble is, it's very expensive, and so it's not they're not freely available in the state sector. We don't use it at all. You start 1 week before, and you give it for the whole 7 weeks of the radiotherapy, and then you stop. And it has been shown to have good effect. But we don't, there are other drugs. I mean, you can use hydroxyurea, you can use other things, but we don't. We use the sort of gold standard, which is to use the platinum agents. They, sort of 3 times during the treatment, if we can get them to finish the treatment, because sometimes it's difficult to get the full 3 cycles in. I don't know if that answers the person's question, because I don't know if they were thinking about other radiosensitizers, but those are the ones we stick to, cisplatin.
Great. Thank you very, very much, Dr. Wetter. I think we've managed to go to about 60 to 70% of answered 60 to 70% of the questions on the chat function. And in the interest of time, we'll stop it there. There's one question on how we can get recordings. I've just put the link up on our YouTube platform.